venous pressure, or how much volume is in your circulation. And afterload coming out is how much resistance your heart faces in the form of systemic vascular resistance or the blood pressure that we test. And then the heart is required to pump enough cardiac output, and to do this it has to pump enough volume, which is stroke volume, per minute, so it needs to have good heart rate. And so the problem with shock is decreased perfusion means we have decreased cardiac output, which is either because the heart is facing so much resistance that it cannot contract, that's why it has low cardiac output, or because the heart has failed to contract because its muscles are weak. In this case, it will be cardiogenic shock. Or it could be because the heart is not receiving enough preload or enough volume to begin with. So this is hypovolemic shock, and it's the most common type of shock. And also, if we have decreased systemic vascular resistance so that all the blood is being pulled in the circulation and is not reaching the heart, it's still gonna decrease the volume going to the heart. And this happens with septic shock, for example. And so the key to differentiating the types of shock, which all present in the same way with hypotension, with decreased perfusion to organs, the key differentiating feature here is central venous pressure. If the central venous pressure is low, it means not enough blood is reaching the heart, so it could be hypovolemic or septic. But if central venous pressure is high, it means it's cardiogenic because the heart is not pumping enough, so it's congested behind. So this is a brief overview of shock on all the up and down arrows. So we can start the game, I guess.
Okay, all right. And I should mention that I didn't talk about Omar and Noor are editing the game, but they're also very strong scoring on the step one exam, like very high scoring, and so Noor also has a YouTube channel where she explains topics in medicine, and it's very good. That's how I was exposed to her teaching style, and I liked it so much that I reached out to her, and she was willing to help out on the game. So, I definitely appreciate the way that she explains the topics, and so she will occasionally help us out, hopefully, and come and do some lectures with us. But that was great. All right, so we'll just jump into the game because I think a lot of you guys are coming back for an additional meeting. So, Noor, if you could transfer host status, I'll share screens and then. Let's see here. Got it. All right. So let's see. Screen 2. Share here, and I have a window open. Has anyone who's here not seen the game or played the game in a Zoom meeting? I don't think so. Okay. All right, let's get started here. So, do you guys have a preference on what kind of character we play? Nobody tends to say that they do, but we. All right. Step 2. All right, you know what? Let's play a knight because we've not done that yet. All right, we'll play step 2 here. And so here we go. So very soon we're gonna have multiplayer. I know I've been saying that for a while, but some of the development has been on pause because we've been using our developers to make a back-end development task that is making multiplayer, and we're on the verge. So some of our videos are going to involve inviting players to play along with us in the video, and they can watch the Zoom meeting while they actually play the game with us. So I'm just going to skill up some things. I believe this is the highest. If we do a bunch of damage here, I think we'll do pretty well. And I'm using these action points to move within the game. And I'm using these vision points to kind of see where I'm going and what will be there when I get there. And it looks like we have a spider and another spider here. Alright, so I'm going to skill this up. And Rowenda, do we have somebody we might have the first question for?
Yeah, sure. Hello, everyone. So our first is Rahul.
Raul, alright. Hey Raul, alright. So do you want to read or should I?
Well, I've never played this game before. Could you tell me how it works?
Oh, absolutely. So we're about to answer like a vignette style question. Like, have you taken step 1 or this is?
Yeah, I've taken step 1.
Okay, so these are just classic vignette style questions. You read them out and then we pause and you kind of think out loud about what you think the answer might be or what you don't like about some of the answer choices. Often, if we don't know the answer, we'll just talk about why we don't want to choose certain answer choices, and then we'll get the whole group involved if we really don't know what's going on. Given the fact that we have Omar and Noor here with us, we're probably going to know something about it, but no pressure. You're not, but eventually you choose one of the answer choices, you choose a level of confidence, and we discuss why the answer was right or wrong. So, so I'll just hit the answer question. You can read away if you would like.
Okay.
All right, let's do it. I'm gonna attack one of these guys just to show you. We're trying to survive. So this is our hit points. This is our mana. This is our thirst. This is our hunger. We have some items here, and we have some spells and things we can do. So we're trying to get to the latest stage we can before we die. All right, let's do it. Are you able to see and read this?
Yep.
All right.
67-year-old man presents to the ED after a suicide attempt. The patient was found in his apartment by his grandson with wrist laceration. He was rushed to the ED and he was resuscitated en route. He has a PMH of ischemic heart disease and depression. His pulse is barely palpable and he's not responding to questions coherently. His temperature is 98.2, blood pressure is 107/48, pulse is 160, respirations are 14, O2 sats are 99. The patient is started on blood products and his blood pressure improves to 127/55 after 3 units. On physical exam, he complains of numbness surrounding his mouth and pain in the location of the laceration of the wrist. Which of the following best describes one of the lab findings that could be seen in this patient? Well, the numbness towards his mouth, especially after he got the units of blood, makes me think it's hypocalcemia, but because of the increased citrate that's coming out from the breakdown of the RBCs.
Yeah, that's great. So you're saying you like hypercalcemia, you say?
Actually, it's hypocalcemia, isn't it?
Hypocalcemia.
That's what I was thinking. Yeah.
Yeah, because you look at the answer choices and you're like, oh, because there's hypomagnesemia, hyperkalemia, and then hypercalcemia, no lab abnormalities, or increased free iron. So one of the things I'll mention is usually the timer would be running, but I'm pausing it just so we can. Okay. So we're trying to earn action points, so we can move, we can attack more if we earn action points. And so the higher confidence, the more accurate we are, and the sooner we answer questions, the more action points we get, which is not to apply pressure to you now, like obviously, and it seems like you're working towards an answer anyway. But just explaining how this format works to your favor or to your detriment. If you were to say you were really high confidence and you were wrong on an answer choice, it would like do damage to the character. So I'm just explaining the game because every video there's someone who has never seen the game before. So so we record the session, so it's good to explain it to people who are viewing. But so this is a 67-year-old guy, and he had a wrist laceration, and he was kind of like his vitals were compromised. And then we gave him some fluids, and it seems like his diastolic is still dipping a little bit. Would you say?
Mm-hmm.
And
Yeah,
then
yeah.
he has numbness surrounding his mouth and pain on the location of the lacerations of his wrist. So, which of these answer choices kind of would you say? And Noor and Omar, if you have something to like questions you might ask Raul, or if you have some insight into something we might not have highlighted, let us know. But
Yeah, Rahul,
yeah.
you should highlight 3 units of blood. 3 units is a lot.
Oh yeah, that's a great point. So
So
three,
what's the electrolyte abnormality with heavy blood transfusion?
right, right.
Right. That would be hyperkalemia, isn't it?
Yeah, I mean, so you can definitely get iron if you have thalassemia, for example. You can get iron overload, and then
True, true.
so there's some things you can get, but what this guy's experiencing, numbness surrounding the mouth and pain in the location of the lacerations of his wrist. So
Also, hypomagnesemia presents the same way as hypocalcemia.
yeah,
Oh,
they're both like
citrates, chelates, calcium, and magnesium.
yeah. Oh, okay, so
okay.
those things can be.
That's interesting.
So you get Rousseau's sign and Schwastik sign.
Yeah.
Yeah.
So let's pick an answer choice, and don't worry about it. We get things wrong quite a bit here,
Okay.
and we'll just we'll take a look at it.
All right, let's go with hypomagnesemia.
All right, let's do it. So what confidence you want to go? What color?
The middle one, yellow.
Yellow. All right, let's do it. All right. We got some. See, we're getting attacked by two things right now, so we should probably just like move backwards. I think I'm gonna go to E3, and we'll regroup. I might even go up here so we can get away from the other spider. All right. So thank you, Raul. All right. So let's look at this answer choice. Just read the quick explanation. So transfused blood products contain citrate, which can bind to calcium and magnesium and lead to hypocalcemia or hypomagnesemia. And so that's a great insight that like the clinical picture is so similar to hypocalcemia, but you're not seeing a hypocalcemia answer choice.
Right.
So if you see something that suits a calcium observation but isn't calcium, magnesium's a good choice because they're both like they're both positively charged +2. Yeah. And they act very similarly in terms of symptoms.
Right,
I say
makes sense.
yeah. So if this was hyperkalemia, for example, you could have like hyperkalemia could occur in hemolytic anemia, but not like necessarily. They're not thinking of this as a muscle weakness, cardiac abnormality. Yeah. All right, so that's a good one. So thank you, Raul. So Rowenda, so who do we have next here?
B. Hi, B.
Hello, B.
Hi.
All right. So would you like to read or should I?
Okay.
All right. We'll let you. All right. Let's get started here.
All right.
So.
So we have a patient. He's brought to the emergency department by his spouse. The patient is admitted untreated and transferred to the floor. He has past medical history of obesity, type 2 DM, asthma, depression, and multiple suicide attempts. His current medication include pantoprazole, insulin, metformin, albuterol, fluticasone, lithium, levothyroxine, and fluoxetine. The patient has 20 years smoking history on the floor. Temperature is 99.5. Blood pressure is 140/85, which is slightly high. Pulse is 70, respiration 13. Oxygen is 98% on room air. The patient's initial radiograph is reviewed and as seen in figure A. Which of the following is most likely the etiology of this patient's initial presentation? So
All right.
let's see.
So I'll show the figure and then we'll pause it.
Okay.
So what are you thinking?
Okay.
Oh, you're thinking answer choices already. That's great. I was just thinking like interpretation in terms of the chest X-ray.
Mm-hmm. Um, I've seen this chest X-ray before, but I think something is happening within the pulmonary vein.
Okay.
This thing by the side, I don't know, looks like something is going on there, but I don't know how to interpret the X-ray.
Yeah. I'm seeing a few things. I'm seeing maybe some hilar. Would you say there's some infiltrate there? Maybe not. You think?
Maybe.
Maybe? And
Also,
then,
there's air under the diaphragm.
exactly.
Yes.
Oh yeah, there's air
So
Look
on
under that fan.
so what does
Yeah.
that suggest?
Air on that diaphragm, that's perforation.
Yeah, exactly. So I think if we look at the clinical profile and we notice this is like, a huge red flag. So then we look at the potential causes of a, bowel perforation.
Uh-huh. Um, what could be cause? Um, maybe E?
Infected mucosal outpouching, yeah. So that would be something like a diverticulosis or diverticulitis.
Yeah, that's not what's going on.
I mean, I don't know that that's a terrible guess. Do we want to tap? Do you want to see like what Omar and Noor are thinking, or you think you want to guess first, and we can parse it out? Which answer choices don't you like?
Okay, I don't like D.
Okay, and D kind of relates to like maybe ulcerative colitis.
Yes.
Yeah.
Um, here, multiple sclerosis. What's going on here? I
So
don't think I like B.
D, yeah. Okay. So yeah, I mean, this person's taking metformin for diabetes. Could have some dyslipidemia. Could have gallstones for that. It's a male, just not female 40, and getting gallstones.
Yet an impacted gallstone is an uncommon situation for perforated viscous
Yeah,
with an air under diaphragm.
yeah. I mean,
It
even
would be
if you
a
had,
case report.
yeah, like even if you had a gallstone ileus or something, like there's no air. It's not getting a pneumo, you know.
Pneumonia.
Yeah,
More pertinent.
yeah. So
Or splenic laceration too won't present with an air under diaphragm.
right, right.
And
That's
there will be a history of a trauma.
right. So you were initially saying E. Why were you thinking E?
Because E kind of sounded close to, okay, what I was thinking of it, okay, having hair under the diaphragm, I feel like if there's an infection, outpouching, like that's closest, there can be like there can be hair also involved in the outpouching of the membrane. That's what I told her.
Yeah,
Because I don't think AV malformation would cause it either. I've not seen AV malformation causing hair on that diaphragm either. So
yeah, because
Especially with feverish, it's infected.
yeah, yeah, because it's like this is kind of the symptoms. You might have hypovolemia or maybe a cold blood, bleeding. And you might have like potentially
I think
like
the blood
anemia.
pressure will be higher than that, most likely.
Yeah, or like anemia. You know. So let's choose one, and then we'll I'm gonna turn the timer on to apply
Okay, now
time
let's
prep.
go
E. All right. What confidence we want to go with?
middle.
Middle. All right, let's do it. All right.
Let's see.
All right, so we gotta attack one of these guys because we're getting like walloped right now. We got it. That was good. So it sounds like they are highlighting exactly what we did. I was looking at this a little bit, but I think that's just it's not going to be sarcoid or tuberculosis. So free air into the diaphragm. Anything that can compromise the intestinal lining is probably higher, chance of being the correct answer than anything else if they're asking about the cause. So that's great. Thank you, B. And so, Rowenda, who do we have? Who are we thinking?
Yes. Hi, Erwin.
Erwin. Okay, good to see you.
Hey, I'm in the library right now.
All right, let's do it.
Okay.
Can you see that yet?
Yes, yep.
You're welcome to read if you want. I can read if you like.
You can read. I'm in the library. I'd like to.
Oh, okay. So, 65-year-old man presents the emergency department for a loss of vision. He was outside gardening when he suddenly lost vision in his right eye. So then he immediately called emergency medical services. But by the time they arrived, the episode had resolved. Currently, he states that he feels fine. And patient has past medical history of diabetes and hypertension. His current medications include lisinopril, atorvastatin, metformin, and insulin. His temperature is normal. His blood pressure is slightly hypertensive. And, he has diastolic hypertension for sure. Pulse is 90. Respirations are 12 per minute. And oxygen saturation is 98 on room air. Cardiac exam is notable for systolic murmur along the right sternal border that radiates to the carotids. So, systolic murmur along the right sternal border that radiates to the carotids. Pulmonary exam reveals mild bibasilar crackles. And so, neurological exam reveals cranial nerves 2 through 12 are intact, and he has 5 out of 5 strength and normal sensation in the upper and lower extremities. The patient has negative Romberg's maneuver, and his gait is stable. So he has a bunch of normal neurological findings. A CT scan of the head demonstrates mild cerebral atrophy, but no other findings. Which of the following is the best next step? So I'm just going to make this slightly smaller so we can see it. All right, so what are we thinking?
Alright, I'm thinking about a transient ischemic attack. Probably a thrombotic event from systolic murmur. Maybe it's a stenotic event too.
Yeah, what valve would you think was stenosed?
So aortic
Yeah.
radiates the carotids.
Oh, this is the right sternal border. So yeah. So the right sternal border is interesting. I think the right sternal border, correct me if I'm wrong, Noor and Omar, tends to be like regurg for non-valvular reasons, and then it might be valvular or non-valvular. And then
For the aortic region, and here it's systolic, so it's stenosis.
yeah. So yeah, it's strange that it's on the right to me, because the left would it would usually be upper right, but it's not. They're saying that it's right sternal border. I guess maybe they mean upper or right, but yeah. But yeah, so I think it's got to be, yeah, because it's systolic. You're right. So you're thinking like maybe a transient ischemic attack?
Yeah, from an embolic event, or it could be a stenotic or carotid. Well, I was thinking about the carotids, but I don't know if that's reaching. So
You're thinking about I didn't catch that. Sorry.
carotids.
Ah, okay, yeah, the carotids, like maybe a stenosis of the carotids. Yeah. I think that's very fair. The fact that they mention a murmur, suggests. I think the sound that you're hearing in the carotids is probably the stenosis because it does radiate to the carotids. But I think the most common source of transient ischemic attack is usually the carotid stenosis. I could be wrong. So what are we thinking for answer choices? How do we like these answer choices? Oh yeah, so Erwin is in the library, so he's chatting. So I'll just read out what he says if he wants to type some things in. You can be brief. We can also talk out loud while you kind of just give us kind of an answer in text. Erwin's grandfathered into chatting by chat because he's been here so many times and answered so many questions on YouTube. So Erwin, do you have? Yeah, he's thinking. Okay, so I wonder if Noor or Omar have any thoughts that they're.
Yeah, I'm thinking that the aortic stenosis is just a coexistent finding, but let's think of the most common cause of TIA here and listen to his carotid bruit. It has to do with thromboembolism of the carotid, I guess.
Yeah, yeah, I think that's right. I think usually it's something that broke off of a thrombus forming in the carotid, so it might be good to investigate. So Erwin's thinking A as well. So what color should we choose, Erwin? I'll turn the time on. All right, he's thinking yellow. All right, let's give it a shot. All right, we are batting 100. I mean, we're like batting perfectly right now. So I'm going to kill a spider real quick. Strange sentence. And we'll search it. Okay, it doesn't have any. Oh, it has an item. All right, we have a short dagger here. All right, gloves. We should pick those up. I'm going to. All right, thank you, Erwin. It looks like we got it. So let's see what they're saying about it. So amaurosis fugax, fugo. It's an acute episode. I think they're going to say that you need to check the carotids. It's a TIA as you diagnosed correctly. That was good. And then we got painless loss of vision. And so we are thinking like carotid source of emboli. So that's a good one. That's like, it's good to notice like that the stenosis is happening, but that there are other causes that are like, more common and that we should investigate. So, all right, so who's next? Should we go to Raul again?
Yeah, Rahul.
All right, we have a small class today,
Sure.
so yeah, all right, let's do it. All right. Okay.
Alright. A 67-year-old man presents to the ED after fainting while mowing his lawn. He stood up after his riding mode and fell to the ground. He woke up within 10 seconds and went back to his baseline. He has a past history of diabetes, high blood pressure, and 40-year back smoking history. He denies any chest pain or dyspnea during this episode. His temperature is 98.7, which is normal. Blood pressure is 152/99, which is high. Pulse is 60, respirations are 15, and O2 sats are 98% on room. Physical exam is notable for an obese man, and he's in no distress. Cardiopulmonary exam is unremarkable. There is trace bipedal edema observed in the lower extremities, and EKG is performed as shown in figure. A chest radiograph and head CT are performed and are unremarkable. What's the most likely diagnosis? Could
All
you
right.
open the figure? Yeah. Okay.
Yeah. So how do we want to go about it?
I see these peak T waves.
Yeah. Crazy T waves.
Exactly, yeah. And well, there are discernible P waves.
Yes.
So
it's not
it's not
AFib.
AFib. Yeah, it's not AFib.
Yeah.
Peak T waves. I suppose that's more in hyperkalemia, right?
Yes. Yeah, and you might get U waves.
Right.
Which, I'm not sure if this is representing something extra here with the U waves. it follows the alphabet Q, R, S, T, and then you got the U here every once in a while if you have hyperkalemia. So I don't know if that represents a U wave, but
Yeah.
you also have potentially a Q or S that might have existed here, might have existed there.
Yeah. So I guess we could say that's a heart block, I guess.
Yeah, I mean, I'm not sure if I think heart block specifically would refer to like specific AV or SA nodal or like ventricular source, like bundle of His sourced. What do you guys think, Noor and Omar,
Look
about
for
this?
the PR interval. Look
PR
for
interval.
yes,
Yeah.
look for the sequence of each complex.
Yeah. So
Right.
you have the P wave here, and then you have the R and the QRS, which is
And
the
then
Start from the first one,
yeah. So you look here and the distance here.
then there's this is a drop,
Thank you.
the beat after the drop check.
Yeah. So
Yes, Omar is saying that there is a P wave that's not followed by QRS. There is a drop beat.
yeah.
Yes.
Got
And
it.
the next new complex with a short PR interval, then it is prolonged, and the third one is more prolonged, then there is a drop.
Right. And so if you're getting successive prolonged PR intervals, then you might be thinking about a Mobitz 1.
Mobitz 1, yeah.
Okay.
Right.
And so is that so? Do you what do you think, Raul? Are you?
Yeah, I'm thinking the same too.
Do you see that? Yeah, I think that's pretty good.
I agree with Omar. And, yeah.
Okay. All right. So let's so do we have a Mobitz 1 answer choice?
Yeah, we do.
All right. What confidence are we thinking?
Let's hit green for this time.
Okay. Let's do green and I just wanted to read the answer choice here and see if there's any sources of AV. So is Mobitz 1 an AV node generated arrhythmia?
It's not exactly an arrhythmia. I think it's a block, right?
Yeah, so like would you treat it with ppm? Or would you
I don't think so. No, Mobitz 1, we don't.
Right. Yeah, you don't. So, all right, that's great. I think we got that one. All right, looks like we got it. We are not getting anything wrong, guys. It's almost as if I invited two people who score really well to join us. So they did highlight what he was saying, the progressive PR intervals, and then the lost beat.
Right.
And so that signified to him a Mobitz 1. That's very good. So, so you can highlight this if you're playing the game, and we'll go to a review section of the game, and we can actually review questions. We can flag it. So I'm going to flag this question, and if we go to the review area, we can actually see which questions we flagged. So I can't, with a knight, I can't attack the enemy, but the enemy can attack me from this position. So I'm going to move here because I know that I want to pick up an item eventually. So I'm going to do both, move into a attack formation, but also into a place where I can pick up an item eventually. And we'll kill a spider. Alright, so now that we've actually completed the level, we're getting like 4 action points to move over and grab some items real quick. So I'm going to pick up this with the hotkey D, and then we look at the backpack, and we can look at our character and equipped some gloves. So I'm going to equip that, and now, although you can't see it, the character is wearing some fashionable gloves. And so now we can move on. We can press this button, and we can move on to the next stage. So it looks like we got 4 out of 4 right, which we can do better, but that's pretty good. And I'm just kidding. And then, so then we move on to the next stage. And now I'm searching for the next, oh man, we got so many spiders here. infestation. So who's Rwanda? Do we know? Do we have? I'll just rotate through because we really don't have that many people. So let's go with B. B, are you here? B, if you want to answer a question, you can. I think Raul just went, and Erwin's in the library and also went more recently. So I'm gonna put her in the waiting room because every once in a while she gets a notification, or the person that I put in the waiting room gets a notification. They can come back and say hello. So that'll like give ring a little bit in a way that I can't produce with the microphone. But let's do. Erwin, if you want to do another one, let's just alternate here, and I'll read the chat. If you don't mind, we'll have a little more involvement from the tutors, just because you're in the library, but you'll also get to choose an answer before anybody. And I'll just read it out loud here. Okay, let's do it. So, 60-year-old man presents to the emergency department complaining of worsening exertional dyspnea over the last week. He denies chest pain and lightheadedness, but reports persistent cough with white sputum. So his past medical history includes hypertension and diabetes. He has a 50-pack year history of smoking, but denies any illicit drug use or alcohol consumption. And his temperature is elevated at 38.3, and he's very hypertensive at 154 over 104. His pulse is 110 with hypertension, and his respirations are 26. So oxygen saturation is at 88% on a non-rebreathing mask. And physical exam is notable for an obese man in distress. The anteroposterior diameter of the patient's chest is increased. And he has decreased breath sounds bilaterally with diffuse expiratory wheezing. Which of the following is the best next step in management? All right, so I'll pause. So what are we thinking here? I'm eating breakfast, but I'm eating lunch. But so it looks like Erwin's saying, COPD with obstructive sleep apnea, OSAH, like a combination of both of them. So, yeah, I mean, he has an elevated temperature as well. With the hypertension and the pulse, and the kind of acute presentation that we're seeing, I mean, it's presenting over the last week, but, can we tolerate like an 88% oxygen with COPD?
No, he actually diagnosed correctly. He mentioned it's a COPD exacerbation, an acute exacerbation.
Yeah, oh, okay. So he's saying exacerbation, probably more of a COPD exacerbation, exactly. Yeah, so what do we think, if that's the presumptive diagnosis, what are you thinking in terms of good or bad answer choices? Yeah, so he's saying he's ruling E out because we need beta agonists. So I like that. So alpha 1 and alpha 2 doesn't do anything. So yeah, I agree that, yeah, it's almost like yeah, these are like vascular constrictors and dilators. Alpha 2 is kind of a central dilator of the peripheral vasculature, and then alpha 1 is kind of a peripheral constrictor of the smooth muscle in your vasculature. So muscarinic blocker would be a good choice, he's saying, but steroid is more powerful, and he said he would go with B and see if oxygen improves afterwards. So you're thinking B. What color do you want to go with? It sounds like you're nailing this question. So, all right. So I'm gonna go with green. Okay, yellow. All right. You know what? All right. I'm gonna go with green. All right. Let's go with yellow. I'll just go with the answers. I'll be strict on Okay, all right. So we got muscarinic. So you were right about the confidence then. So let's see about this. So the treatment of COPD flare involves administration of bronchodilators, albuterol, and ipratropium. So glucocorticoid analog. So the way that I think about this is like it's like asthma in the sense that like
Exactly.
yeah, you wanna get a beta agonist and dilate your bronchioles and your bronchus. I mean, and so like you can follow it up with a glucocorticoid, uh, but your first line is going to be ipratropium and a beta agonist. They would never put. Yeah, I don't think you could choose both answers. And a beta blocker is like that's going to cause bronchospasm and it's contraindicated in asthma to do a beta blocker. Um, is that what you guys were
He
thinking?
has disease,
Yeah,
because
you,
he has disease right now, we need to dilate in order to improve his oxygenation, then do anything else.
right. Yeah, yeah. I think acutely. Let's see what they say. Glucocorticoid analog are indicated in acute COPD flare, but take hours to take effect. So if you gave a glucocorticoid, you might be waiting for them to become like hypoxemic in the meantime. Yeah,
Yeah.
yeah. So that's a good one. I think that's also like in hospital a good one to just see over and over again in questions, so you like never have that issue. But yeah, no, that's a good one. So all right, thank you, Erwin. Yeah, I mean, in hospital, he's saying he would give both. So, like, yeah, that's clearly the case. I think you would give oxygen and you give antibiotics and you give all sorts of things at the same time. It's funny that they ask questions about what to do first. But it's a nice insight that one is short acting and one is kind of, you know, takes a little bit longer to kick in. So, I guess we're back to Raul until we see B again. Raul, are you?
Yep,
All
let's
right,
go.
let's do it.
65-year-old male is evaluated in the clinic approximately 6 months after resolution of a herpes zoster outbreak on his left flank. He states that despite the legal having recovered, he's still experiencing constant burning and hypersensitivity to touch in the distribution of the old rash. You explained to him that this complication can occur in 20 to 30% of patients after having herpes zoster. Also explained that vaccination with the shingles vaccine in individuals 60 to 70 years of age can reduce the incidence of this complication. What is the complication?
Yeah.
This is post-herpetic neuralgia.
Yeah. Yeah. How would you treat this?
Post-herpetic neuralgia. I believe it's gabapentin.
Yeah, that's perfect. Yeah. So, what confidence are you thinking?
Green. Let's go
Yeah,
green.
I think it's safe to say that you could have gotten a harder one right as well. So that was great. So let's kill a spider while we're at it. Here we go. All right, so let's get back to Erwin, and we'll I'll read this out for us. So 63-year-old, everyone's a 63-year-old today, 60s. So history, obesity, poorly controlled type 2 diabetes, 93%. So 9.3. So presents with 1 week of worsening swelling, redness, tenderness to the touch of her lower extremity. She reports no sick contacts and no recent travel. 1 week ago, she slipped on her cement driveway while bringing groceries into her house, but otherwise reports no notable events might have preceded her symptoms. She felt warm last night but did not measure her temperature. The woman's temperature is okay, it's normal. Blood pressure is reasonable. It's almost type. It's kind of getting there. Pulse is elevated with slightly elevated blood pressure, and you have respirations at 16 and room air. So a physical examination is notable in the findings depicted in Figure A. What is the most likely diagnosis? So let's check this out. So it looks like what are you thinking, Erwin? Yeah, cellulitis. Yeah, I totally agree with that. Yeah, hands down. Yeah, I think this one. I would say that this one's a little redder than this one. Yeah. Yeah, I agree. Um, something's going on with that toe, but all right. So I don't even think we need to look at that photo too much. Um, so which of these answer choices kind of are we thinking then? Hands down, green. You're saying cellulitis. All right. So are there any differentials that we might consider a little bit though? Do you think it's necrotic at all? I don't. I think you're right. Yeah. We'll speed this up. We tend to get everything right in this session, so.
Right.
All right. So that's great. All right, that was very good. I think you guys are killing it right now. So let's go to. I'm gonna skip that corner, although we might need to investigate it later. That might be a pain. All right, so Raul, let's keep it trucking, I guess. Let's do it.
Okay. So a 23-year-old woman presents to her primary care for poor sleep. Her symptoms began a week ago when she started waking up multiple times throughout the night to urinate. She also reports an increase in her water intake for the last few days prior to presentation, as well as larger urine volumes in normal. Medical history is significant for asthma. Family history is significant for type 2 diabetes. She denies alcohol, illicit drug, or cigarette use. Her temperature is 98.6. Blood pressure is 108/65, which is normal, I guess. Pulse is 103. Respiration is 18. On physical exam, she has mildly trimucous membranes and no focal neurological deficits. Lab testing shows. Could you scroll down? Yeah, thank you.
Sorry.
Sodium 145, which is slightly high, but it's normal, I believe. Fluoride 102, potassium 4.2. Bicarb is high, yeah.
Yeah. And so, yeah. So then we have urine osmolality at 250.
Yeah. And she undergoes a water deprivation then. Okay. Let's see, sodium increased and urine osmolality is still high.
Yeah.
Okay.
It's almost the same.
Yeah.
Yeah. Almost the same, yes.
Yeah. So I'll pause. So what are you thinking about?
Well,
How would
it's
you
not
just because there might be people watching the YouTube video, and what are you thinking about in terms of like how would you like summarize kind of in a brief way why we did the water deprivation?
well, we're trying to see if she's having like a psychogenic polydipsia, I believe,
Yeah.
and yeah, and just to see if that is gonna correct the urine osmolality or any of the issues that she's been facing. But then clearly here there's no change. So the option B, the counsel to decrease excess water, would be ruled out.
Right. Because you're kind of distinguishing between like diabetes insipidus or primary
Yeah.
polydipsia.
Right.
Yeah.
And her bicarb initially was high, but I mean, before it was 28 and after the deprivation it's 22.
Right.
It's not
Still within
super
normal.
high.
Still within normal range.
Right, yeah. So, yeah. I'd also rule out the dietary modifications
Yeah.
because nothing here that tells me that it could be related to that, you know.
Yeah. I'm not sure what that answer choice is representing in terms of a diagnosis. Do you guys know?
I think maybe the, what do you call it, tea and toast syndrome?
Oh.
So here he's wanting to make sure that this is either diabetes insipidus versus psychogenic polydipsia, like Rahul said. So if it were psychogenic polydipsia, after water deprivation, her urine osmolality is expected to increase because ADH is produced. But here it didn't increase, even though she stopped taking a lot of water,
Right.
which means there is ADH deficiency, whether neurogenic or nephrogenic. So to differentiate, we need to administer desmopressin to her.
Desmopressin, right? Okay,
Right.
fair enough.
Right.
Also, another hint about psychogenic polydipsia, the initial or baseline sodium level would be much lower at the
Right.
lower normal range, not at the higher end.
Right.
Yes.
Right.
Exactly. That's a
Yeah.
great point because
Makes sense. Yeah.
you'd be at have a dilutional effect on the yeah. So that's a great point. So what is the difference, Raul? Like, how would you explain the difference between like I'm just because this is a good question for anyone because it's the question everyone forgets the details behind because they flip the signs between SIADH and diabetes insipidus. But how would you describe the difference between nephrogenic and central diabetes insipidus?
Well, um, central, the way I remember it is like central because the pituitary makes the ADH, right? The posterior. Now, if it's central, then obviously there's no ADH in the system, and then the treatment is desmopressin.
Right.
Whereas if it is nephrogenic diabetes insipidus, then more than likely it could be due to some other drug, like if the patient is depressed or something, they could be taking lithium.
Right, right. Which is
Yeah,
that's a nephrogenic diabetes insipidus cause from
yeah,
iatrogenic. Yeah,
yeah.
so that's great. Yeah, that's a good explanation because I like this disorder to go over it a million times because all right. So what confidence do you think we have for? I guess we talked about C.
Desmopressin.
Yeah.
Yeah, I guess we can go green actually.
All right. Let's do that. All right. All right. We're batting. We're doing very well now. So that's great. So I can't shoot this guy because I'm not an archer, so I got to go around. All right. All right. Oh my God. Okay. We got a goblin finally. It's not a spider after all. Erwin, I won't ask you to say anything, but I'm gonna read the question out for us. 34-year-old man, motor vehicle collision, front seat unrestrained driver, high-speed collision. The patient is complaining of significant chest pain, and the primary and secondary surveys are remarkable only for bruising over the patient's anterior chest wall. His temperature is normal, his blood pressure is decent, his pulse is high normal, maybe elevated at 100. Respirations are 18. It's really on the border, and then oxygen saturation is 98 on room air. Chest radiograph is performed and seen in Figure A. The patient is complaining of ongoing chest pain. Which of the following is the most appropriate next step in management? So then we look at the photo here, and yeah, so this is not a normal X-ray. So I would say that the place where you would expect like the aortic notch is kind of obscured by something else, right? And we have the trachea seems to be deviating as well. We also probably have cardiomegaly here, and it almost looks like it's boot shaped, but it's not. I wouldn't use that terminology, but it's an enormous heart. What do we think this is? Do you guys have any idea? I'd say that might be like a descending aorta. You think? What do you guys think? I don't know.
Aortic rupture, you mean?
Yeah, I mean, let me look at the vitals here. So the vitals aren't egregious, but we're getting up to the point where we're going to be tachycardic. We're not quite there yet. We have some ongoing chest pain, and we had, a high-speed collision. So I was thinking it might be a acceleration, deacceleration.
Yeah.
Yeah. And at the ductus arteriosus, you have kind of some integrity issues from acceleration, deacceleration that could cause like a dissection. So it might be like a Stanford, A.
Yeah.
I was thinking about that. So I almost think that maybe, yeah. So Erwin, what are you thinking in terms of answer choices? Oh, I'm not reading your chat. Okay, so we've completely nullified. So he's saying it's probably D. He's saying widened mediastinum or aortic dissection, and he's saying do a CT. Okay, could be tamponade. He's saying, yeah. I mean, we don't have blood pressure decrease yet, but I think it's going to be a tamponade. I was thinking cardiac contusion at first. Yeah, I was thinking about that, but we didn't have any. I wouldn't say that we had like cloudy edema or anything. Um, and it doesn't specifically talk about like an anterior. It says anterior chest wall ecchymosis, but nothing on radiograph or like. Usually they'll give you imaging for a contusion and be like, give you some hint. But CT first, get extent of damage. He's saying so. He likes a CT. What are you guys thinking? What confidence? Yeah, patient is stable. He's making a good point on that. Although I think that chest X-ray is very abnormal, so I'm very worried about the patient even if they're stable. But what confidence do Erwin and then I think we might speculate even after that. It's hard. Probably yellow. Yeah. All right, we'll go yellow confidence. So what are you guys thinking, Omar and Noor?
Patient is hemodynamically stable yet. Uh, he could deteriorate at any time,
Yeah.
but a triphasic CT or CT with contrast is essential for surgical plan.
Yeah. Yeah.
I think so too. If he were unstable, I would choose E.
Yeah. Yeah, I would choose E as well. Yeah. I mean, I might even consider pericardiocentesis to get, because looking at that heart, it's just, it's possible that you have a pericardial, bleeding into the pericardium in some way. I'm trying to think if that's, I mean, at least could have a hemomediastinum or, I don't know. So we got
Excellent.
it. Okay, so let's read about that real quick. So they're giving us the mediastinum being widened. Let's see what the diagnosis was. Traumatic aortic injury, hemodynamically stable, so you get a CT scan. So Erwin was right on the money. I think you guys were right on the money too. Aortic transection can present with chest pain, unstable vitals, and rapidly progressive pulselessness. Widened mediastinum. I was looking for that. Yeah. Do you guys think it might be an acceleration deacceleration? I'm not sure that they mentioned it. That might be what they're going for in terms
Yes,
of.
this is my first thought.
Okay. All right. Oh, really?
There is
Okay.
a tear just after the left subclavian artery.
Yeah. Yeah. I think that's right. Okay. Cool. I just want to make sure I'm. So I'm gonna move here and we'll attack this guy. Oh, he's stuck in a corner. This is perfect because he can't. I don't think he can shoot us if he's not further away. Okay, so we've completely trapped this guy. Let's Raul, if you want to answer one, let's do it.
Let's go.
All right, I'm hitting a hotkey for Q, which opens the question. 22.
A 22-year-old man was rushed to the ED after a motor vehicle accident. The patient states that he feels weakness and numbness in both of his legs. He also reports pain in his lower back. His airway, breathing, and circulation is intact, and he is conversational. Neurologic exam is significant for bilateral lower extremity, flaccid paralysis, and impaired pain and temperature up to T11, T12 with normal vibration sense. A CT of the spine shows a vertebral burst fracture of the vertebral body at the T11 level. Which of the following findings is most likely present in this patient? Okay. Normal vibration sense. So that tells me it's anterior spinal injury.
Yeah, probably not a posterior column.
Yeah.
Yeah.
So we can rule out the impaired proprioception sense.
Yeah. This is like a plain and simple. I wouldn't say simple, but I would say that this is asking you about anatomy, and functional associations with anatomy, with pathways.
Right. The lower.
What does flaccid paralysis tell you?
Lower motor neuron injury.
Yeah.
Not necessarily, it could be the shock stage of upper motor neuron illusion.
Right.
True. Yep. Right.
Oh, that's a great point. Yeah.
Yeah.
Numbness in both of his legs. Pain in the lower back. So he has numbness. So
Reserved fine touch.
he has. You said what?
Reserved fine touch.
Yeah, preserved fine touch.
Because it is carried through the dorsal column.
Posterior. Right.
Right.
That makes sense.
Yeah.
Yeah. Actually, yeah. I agree.
That's a great point. Yeah, so this is super anatomical. I'm sure they're going to give us...
Fine touch. Preserved fine touch.
Oh, oops. Okay.
Yeah.
Yeah, crude touch would actually be...
The anterior.
Yeah.
Yeah.
That'd be, yeah. Spinal thalamic? Yeah.
Yep. Exactly.
Okay, so which...
Let's go with the yellow.
All right, let's do yellow. All right, I'll unpause so we can see the animation. All right. See, all you need is people who score in the, in the 99th percentile, and you start doing really well. Anterior cord syndrome presents with involvement of the anterior lateral system, corticospinal tract with sparing of the dorsal column. So fine touch, vibration sense, proprioception. All right. So yeah, we were talking about the, this would be loss of pain. So this is exactly right. You said interior cord. So you remove the right part of the spinal cord to eliminate as answer choices, which is exactly what they wanted you to do. So, and so we're gonna kill a goblin here, I think, in a moment. All right, so Erwin, let's do it. I'll read again here.
Hey Adam,
right.
I'm sorry for this interruption, but I will leave you all
Okay.
at this point. I'm going to the downtown buying few things for my travel to tomorrow.
Okay.
I'm glad to be with you today.
Absolutely. Thank you for joining us, Omar. Appreciate it.
Bye.
Thank
All
you.
right. All right. So, yeah, that was great to have you. So, 60-year-old man complaining of worsening exertional dyspnea over the last week. He denies chest pain and lightheadedness, but reports persistent cough with white sputum. So we already did this. So what was the answer?
It was A, almost.
Yeah, it was A, right.
Muscular. Yeah.
Which represents hypertropium. Yeah. So we repeat. If we get something wrong, it'll feed it back to us, so we can remember it and get it right eventually. And then the summary will be generated by the fact that we get it wrong anyway. So we killed a defenseless goblin here, and we pick up an item, and it's a bunch of potions, so we can move on because we're pretty healthy. So I wanted to we will do more questions until we get to like 1:30, but eventually I wanted to we'll have the character die, and then I'll show you some of the characteristics of the game. We'll have Night and Day coming very soon, and we'll have some changes to the art as well that I really like. And then multiplayer will be coming soon as well. So Erwin, I'm going to read one. I think, let's do that. So 67-year-old woman presents to clinic with a lump on her left breast, and she has noticed within the past month. Her past medical history includes type 2 diabetes mellitus and well controlled with metformin. On exam, her temperature is 37, it's normal. Normal blood pressure, pulse is fine, respiration's fine, the oxygen saturation is normal. There's a firm immobile mass palpable in her left breast. Further evaluation with mammogram and core biopsy reveal a diagnosis of invasive ductal carcinoma. So, which of the following characteristics, if present, would lend itself to the worst prognosis? So, I think this is a tumor grading, prognosis or grading, staging kind of prognosis evaluation for breast cancer. Yeah.
Erwin answered correctly.
Oh, so Erwin did. Okay. So he says D. Okay. So D would represent tumor 1.5 centimeters with fixed axillary lymph node involvement. Was that D that you said? That was for this answer choice? Yeah. Okay. And so what are we thinking? Why are we thinking axillary lymph node involvement is super important? Like as opposed, yeah. Yeah, I think that's right. Like whether it's moved, right? Metastasis. And so is fixed or mobile more characteristic, you know? So not mobile, yeah. So I think that's pretty cut and dry because your lymph nodes ordinarily would be mobile. If they have changed to something that is immobile, then potentially you have some kind of invasion.
Yes.
Yeah. And so, what confidence are you thinking?
I think he should be green.
All right, yeah, he guessed pretty quick. Yeah, we it's a pretty strong group right now. All right, so let's go here. All right, okay, we got a crazy. So this snake, by the way, in the game, like I don't want no spoilers, but this snake is actually a lizard man, and he's going to get more complex. And usually there are things around him that are like different stages of evolution to be a lizard man. So it's kind of cool. So I'm going to try to kill this. All right, let's see here. So next, my game will be done. Thank you for asking, Erwin. So it's not actually even going to be something that you have to download, but people like yourself who come to these lectures quite often get kind of a front row seat to play. Like there's only so many spots we can do in the beginning when we're testing. And so we're gonna have a browser-based game that you can access from Google Chrome or Firefox or any of those browsers, and you can and you can play multiplayer soon. So like when we have these sessions, you can literally be in the game and the Zoom call, playing along with us and killing things. There will be player versus player tournaments actually, and there's gonna be like player versus player. And then it's also going to be 2 versus 2, 3 versus 3, 4 versus 4. So there's going to be a lot of like spell choosing characteristics to player versus player that doesn't translate to playing the the roguelike game here. And so it's going to be interesting. And there's also going to be a multiplayer review game. And so probably the most onerous task of studying for the USMLE is like reviewing questions. And I think it's going to make it very that's something that Omar and Noor are helping a lot with, like writing the summaries, and those summaries are, yeah, absolutely. I'm very excited to show you guys what we're about to put out is probably the furthest we've gotten, and the website's going to be ready for you to access it without downloading the game. So all right, so let's answer.
Sweet.
Okay, so Erwin's leaving, so. Raul, do you want to do one more question and we'll call it a day?
Sure.
And then I'll just show you how the game review works. I think Erwin's seen it before. Thank you, Erwin. Well, I'll see you next week. 31-year-old woman. Okay, so Raul, you can read if you like.
Yeah. A 31-year-old woman presents with a primary care with a 3-month history of fatigue. She says that she used to have a very active lifestyle, but now she can barely make it through the workday without feeling exhausted. She also says that she's been experiencing a lot of pain in her hands and knees. She recently moved into an old house and started a ketogenic diet for weight loss. Her temperature is 98.6, blood pressure is 115/77, which is normal. Pulse is 90, respiration is 14. On physical exam, she has conjunctival pallor and swelling of the MCP joints. Lab tests are performed and There's also hemoglobin is 9.3, okay, very low. MCV 86, iron 37, ferritin 201. Okay. Hmm. Which of the following is most appropriate treatment for this patient? Okay. So this is a normocytic anemia, I'd say.
Yeah, that's a
Yeah.
great point.
Um, she says that she moved into an old house, but I don't think that it's lead poisoning for her.
Right.
Yeah, because that would be, yeah,
Micro.
exactly. Like Ismail said, I do think that it's anemia of chronic disease.
Yeah.
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 Could you
So
could you scroll up for a bit? She had joint pain and pallor. Okay. Okay, just that. Okay. So
kind of.
I would
Yeah.
think that this looks like rheumatoid arthritis.
Yeah. It's like vague anemia with
Yeah,
ferritin's kind of high. So
exactly.
it seems like hepcidin is being, the
Sequestered.
pathophysiology.
Yeah,
Yeah.
yeah, yeah. That would make me think, right, methotrexate because of the joint
Methotrexate.
pain. Yeah.
Yeah, because she's having significant pain in her hands and her knees. Yeah. All right. So what confidence are we gonna go for?
Let's take a yellow on this one.
Yeah, and Ismail is saying, Ismail, do you have
Arthritis.
your microphone working? You can feel free to chime in if you want. So I'm gonna. Which color you want to choose?
Well, I'd go with yellow.
Yellow. Okay. All right, let's do it. Yeah, I think
Sweet.
that's a pretty good analysis of that question. I think the ferritin was kind of like the yeah, and the fact that microcytic anemia usually won't be normocytic. Anemia of iron deficiency. Yeah. So let's attack this guy again. So Ismail, if your microphone's working, we can do one more question. I noticed you joined us a little bit. Next week
I think it's
yeah.
not working for him. Yeah.
Okay.
Yeah.
Okay. Ismail, do you want to do one question with the chat? Although I usually don't do that, but we have such a small group, we can do one more. Does that sound good? All right, I'll read one more and we'll do one more question here. It's almost 1:30, so we'll do it. Okay, let's do it. So, 50-year-old man, primary care doctor following an inguinal hernia repair. The patient reports no pain in his lower abdomen or groin, no constipation, and states that he enjoys his usual diet. He denies any use of alcohol, tobacco, or illicit drugs. He has returned to work as a cruise ship attendant. His preoperative workup included chest radiography, which demonstrated an opacification in his right middle lobe. The patient agrees to undergo CT of his chest without contrast for further evaluation. The radiologist reports that there's an 8mm nodule in the patient's peripheral right middle lobe and has regular margins that appear calcified. So 1 year later, the patient obtains another CT without contrast that reports the nodule is size 10mm with similar characteristics. What is the most appropriate next step? So they did a follow-up, and it's still calcified and enlarged. This is a treatment algorithm for a pulmonary nodule, I would say. Question. Okay, so he's saying A. Ismail, so why are you thinking A? Noor, do you like A as well?
Yeah, I think it's A because it enlarged in comparison to last year.
Yeah. Yeah, so that seems like
There's a risk factor here that he works as a ship attendant. There's exposure to
yeah, asbestos.
yeah.
Yeah. And following an inguinal hernia repair, yeah. So it's an incidentaloma after, status post a cruise ship, being a cruise ship attendant, exposure to asbestos, and then potential lung nodule might be mesothelioma or even bronchogenic carcinoma.
Yeah.
Yeah, so he's saying A as well. So let's go green for A, and we'll finish the session up with almost perfect scores here. It's pretty good. Okay, so PET. We almost got there. Ismail, it's not your fault. That was a hard question. So intermittent risk patient with lung nodule 8 millimeters larger on radiography. The next step in management would be a PET scan. So they're saying that bronchoscopy guided biopsy will be low yield because the nodule is in the periphery of the right middle lobe, not close to the bronchioles. So the location. So we have peripheral right middle lobe nodule. And so the solitary nodule, 8 to 10. So intermediate risk of lung cancer. And so you have to risk stratify first. So if it's spiculated, that would be an increased risk. If the nodule was larger, that'd be an increased risk. If they had smoked, calcification's a risk. And then so you do an FDG to measure the glucose metabolism and thus differentiate between benign and malignant nodules. And so this is as a follow-up, like a 6-month follow-up, 1 year actually later.
I think it's going stepwise here. Like, if I were in the hospital, I would do a biopsy right away, but he wants to teach us to go stepwise, benign or malignant first, and if it turns out malignant on PET scan, then we can go on to a biopsy.
Right, right. Yeah, I think that's right. That's a great one because I would have gotten that. I definitely would have chosen the same answer choice. So yeah, you got to check. You're right. He's saying that makes sense. Thank you so much for coming, Ismail. You're very welcome. And where are you coming from, by the way? I'm just curious. I ask everybody. Oh, Sudan. I think you're the first Sudanese person we have so far. So that's awesome. You're very welcome. And we'll have another session next week. And thank you, Noor, for coming. It's awesome to have you. We get a lot more answers correct when you're around. So, and thank you, Rwanda. Everybody, thank Rwanda. She helps a lot. We'll see you. Yeah, we'll see you next week. All right. Talk to you soon. Bye.
Thank you, guys.
Have a great week, you guys.
You too.
Bye-bye.
Bye.